I was seeing patients every 10 to 15 minutes. I was seeing up to 40 plus patients in a day. And very many of these patients I couldn't help. Looking back at that time, I was in a state of overwhelm and my nervous system was pretty dysregulated. And I've actually gone back into GP after having had a break for 4 years to do my CI work. And I've noticed how dysregulated almost everybody in the system is, from the receptionists to the nurses, to the managers, to the doctors. And I think this is the state that our health system is in. So for me, it was a journey of curiosity and questioning, like there has to be something more. We're missing something. And I became stuck with a lot of patients. They stayed on medication for years, sometimes forever, and they didn't seem to improve, get better, or to heal. And it was when I started exploring childhood trauma, childhood adversity, and the work of Gabor that it opened up a whole other world of possibility for me. And it was then that I started to see really significant shifts in my patients and how they were doing. Difficulties that we have in our lives are actually adaptations to early trauma. And it really changes how we see symptoms and it changes how we see our patients. And it doesn't mean that we have to do more as doctors. It actually means that often we do less.
This is the Gifts of Trauma podcast. Stories of transformation and healing through compassionate inquiry. Welcome back to another episode of the Gifts of Trauma podcast. I am Jim, and today I am here with Aisling Quiery. Welcome, Aisling.
Yeah, thank you so much.
Aisling, you share a beautiful vision for the future of medicine. Why do you believe it's fundamental for medicine to look at the connection between health and early childhood experiences?
So thank you so much, Jem. Thank you for the question. And I think to answer this, I would go back to when I first qualified as a general practitioner or a family doctor in 2016. I qualified as a doctor in 2010 and then finished my general practice training in 2016. And I worked in a very large GP practice in Scotland in an area of high deprivation. And I worked as a GP 2 or 3 days a week. And then 1 day a week, I ran a clinic for patients who inject heroin. And what I was seeing with both of these groups of patients, where in the clinic for people who inject heroin, we were able to do a lot of good work, stabilizing them on methadone, helping them with housing and nutrition, and treating their bloodborne viruses. But what I found was that when these patients became more stable, their trauma would bubble up to the surface. So the reason that they used heroin in the first place would come to the fore. All of them had very high levels of childhood adversity, and many of them also had conditions such as chronic pain, mental health conditions, or other physical health problems. And when they would go to the psychiatrist wouldn't address their chronic pain. When they would go to the rheumatologist or the chronic pain clinic, their psychiatric problems wouldn't be addressed. And when I first read In the Realm of Hungry Ghosts, it started to make sense to me that the root of all of these issues was childhood adversity, and it didn't make sense to treat each problem individually. And simultaneously, what I was seeing with many patients, and I would say probably 2/3 to 3/4 of patients that were coming to see me in my ordinary general practice clinic, were presenting with problems that I didn't have the training to deal with. So these were chronic ill health conditions, what I would now call mind-body conditions, such as chronic fatigue or fibromyalgia, or, very, very many chronic conditions. And I just didn't have in my toolkit as a GP skill to deal with this. And I became stuck with a lot of patients. They stayed on medication for years, sometimes forever, and they didn't seem to improve, get better, or to heal. And it was when I started exploring childhood trauma, childhood adversity, and the work of Gabor that it opened up a whole other world of possibility for me. And it was then that I started to see really significant shifts in my patients and how they were doing.
What do you think was responsible for those shifts? Or like, how did you even come to explore childhood trauma?
For those first early years working as a GP, I was wondering, what is the missing link? What are we missing here? I was always really curious. I couldn't figure out why had I trained for 10 years to be a GP, yet so many of my patients I seem unable to help. And it was when I found compassionate inquiry and the work of Gabor and this mind-body, I won't even say connection, but the mind-body as a whole. When I started thinking in those terms, I started to make real inroads with what I was able to do with patients.
Yeah. So talk about what we have to gain through that perspective.
There's a huge lost opportunity here. I think we are much better able to support our patients to move towards healing, which is empowering for the patient and is also wonderful for us as doctors because we're able to be much more fulfilled in our jobs. We're able, from a very pragmatic point of view, to decrease our workload because if we heal people, we're not just managing symptoms, we're actually helping symptoms to resolve.
Yeah. Talk a little bit about what that shift looked like, how you saw that happening.
What I've seen time and time again is that when patients have this understanding of themselves from a mind-body perspective, that they understand themselves better and they have some answers about why they are struggling with the things that they're struggling with. And in my experience, that almost always avoids unnecessary tests and investigations. And I think we often end up chasing after a diagnosis, and the patient wants answers. And I have seen very often a huge number of tests and investigations that we keep doing, which all come back normal. So I think there's a huge do no harm piece to this as well.
Thank you so much for that answer. There are so many places I want to touch from what you just offered there. First, really, what struck me that I'm feeling into is that first few years as an early practitioner of what that must have felt like for you to have gone through 10 years of training, running this really intense clinic, people with addictions, and we could go back to that time of life for you, because I sense that many GPs probably have a similar experience of feeling unresourced and unequipped after so much training to really deal with the things we're seeing. So there's so many places we can go, but I'd really like to hear about your internal experience in those early years.
Yeah, thank you so much, Jem, for that, because simultaneously, I think my professional and my personal life are running simultaneously. Because when I first qualified as a GP, you were right, it was an intense job. It was also very well supported. I was lucky to be part of a really wonderful team, but I was also struggling with my own anxiety and insomnia and jaw tension. And I would come home from my day as a GP and feel pretty overwhelmed. I remember my jaw got so sore that it would go up into my head and I would get headaches and I found it hard to sleep. And I had had lifelong struggles with anxiety and insomnia, but I think the GP job really exacerbated all of that because of the stress and the busyness and the pressure. I was seeing patients every 10 to 15 minutes. I was seeing up to 40 plus patients in a day. And very many of these patients I couldn't help. And it was a source of frustration. And looking back at that time, I was in a state of overwhelm and my nervous system was pretty dysregulated. And I've actually gone back into GP after having had a break for 4 years to do my CI work. And I've noticed how dysregulated almost everybody in the system is, from the receptionist to the nurses, to the managers, to the doctors. And I think this is the state that our health system is in. So for me, it was a journey of curiosity and questioning, like there has to be something more. We're missing something. There has to be something else going on. And I had that at the back of my mind. And at the same time, I was going to counselling going to physiotherapy for my jaw and finding that what was being offered in the medical model wasn't helpful for me personally in my own healing. And it was when I came across Gabor's work and went to Cork, where he was speaking in 2019. I went to a workshop in Cork, and he invited me to go to a retreat for health providers in the jungle in Peru. And I worked with plant medicine. And it was then that I really began to understand myself, and I really began to experience shifts within myself. And as that happened, simultaneously, I could start to see shifts within my own patient, because I was understanding myself better. I was able to regulate myself better, and I was able to start to make these links with the mind body. And I think it's a really important question, because I think many doctors, almost all GPs, are in this state of being under-resourced, overwhelmed, and having so much to do. And it really stimulates our fixer. And what I mean by that is the part of us that really wants to help and wants to fix. And of course, that's really important. And as GPs, we do often have to problem solve, and that's really important. But I think that part can get in the way. And when we are trying to fix and do all the time in a system where there's too much to do, it makes it really difficult for us to be and to self-reflect. And I think one of the blocks to bringing in the mind-body connection into the medical model is many doctors, perhaps rightly so, we could argue, see it as something else that they have to do, something else that they have to learn, something else they have to incorporate into a job where there's already too much. But my experience was actually the opposite. My experience was when I began to heal my own anxiety and jaw pain and insomnia, and when I began to understand better this mind-body, I was able to do less with patients and get further. And that was very rewarding. But you're right, those early days are very frustrating. Were certainly frustrating for me. And I think we've got two options. And I see two directions that people may go in. One is to blame the patient. This is with no judgment, but we can often become frustrated with the patients. You know, they're presenting again and again and again with symptoms that we can't explain. And of course, that can be frustrating. So one is to question the patients themselves. And the other way that we can go is to question the medical model. If patients are coming and they're not getting better and we don't seem to be able to help them, perhaps there's a deficiency in the medical model. And that's what I started to do, was to question the medical model itself. And, you know, I really want to say here that the medical model is extraordinarily powerful. It is really necessary and it helps lots of people. So I'm very much supportive of the medical model. I just think that there's a big piece that's missing, that if we can find a way to open our minds and our hearts to this mind-body work, that we have so much more to offer our patients.
Yeah, thank you. What I'm really hearing you say is not an outright criticism of the medical model, but it's coming from a place of compassion and reflection of your own experience. When you tell me about seeing 40 people in a day, getting 10 to 15 minutes with each of them, it just breaks my heart to imagine somebody who's followed a life path and truly gone through all of the steps, you know, within that system anyway. And I can also understand how it could be frustrating to feel like I'm still not there yet. There's still more I have to learn. And so I feel the pain and the tension and like the opposition that could present from the idea of asking a deeper question when you only are having 10 to 15 minutes. So you're nodding your head yes. I'm curious to know at this point what you would like to offer if it were up to you to create a new structuring of how people were seen. Ooh, look at that big smile. What would you have to say needs to be changed or shifted?
Yeah, thank you so much, Jem, for that question. And the reason for the big smile was it's a real, you know, it's a really wonderful thing for me to think about, is what the health system could look like if it was truly trauma informed. And of course, more resource, more time for patients and doctors to be able to sit together, is a big part of this. But I actually think there's huge scope for a change in our training so that we don't see symptoms as problems that we want to make go away. And of course, that's not to say that symptoms aren't problematic for patients. And we don't want patients to be living with difficult symptoms, but rather than seeing symptoms as problems that arise as something isolated within the patient, that actually these symptoms are telling us something about the patient's lived experience from intrautero onwards, even from before intrautero, from their ancestors, the culture that they grew up in, their experience in the womb, birth, and early years. And if we have that perspective, we can bring that perspective to patients and really help them to understand themselves better and empower them to find their own solutions with our support. And I think this is one of the key aspects that goes to the heart of compassionate inquiry that really differs from the medical model, is that in compassionate inquiry, we see that everyone has an essence that can't be broken, that is part of who all of us are, and that difficulties that we have in our lives are actually adaptations to early trauma. And it really changes how we see symptoms and it changes how we see our patients. So I think embedding this understanding into education of medical students right from the word go is potential, I think, to be hugely transformative for our patients. And it doesn't necessarily take more time. And it doesn't mean that we have to do more as doctors. It actually means that often we do less. And I think one of the biggest changes that I would make is support for doctors to look at themselves and to actually do some of this healing work on ourselves, because it's so needed. And in my experience, doctors who are taking a different approach or who have stepped outside the medical model a little bit, when you hear their stories, it's often because they've had their own challenges and they've had to go on their own journey of healing. I think all of us are wounded healers, and perhaps you could argue that it makes us better at what we do because we bring our own wounds, and without those wounds, we wouldn't understand the suffering of others. But it's when we're unaware of our own trauma. So I think that's a really important piece. Doctors get almost no support. We get an appraisal once a year, which is maybe for 2 hours talking about some professional goals. But we go into work day in, day out and sit with people who are really suffering and in a lot of pain, and we don't have anywhere to bring any of that stuff. And we're often doing it without awareness of what's happening inside of ourselves. So in medical school and in our doctor training, we're taught to focus entirely on the patient and what's happening for them. And it's compassionate inquiry that has shown me the importance of also being aware of what's happening inside of myself while I'm with the patient. And that is hugely transformative. And I think it brings, when we take this perspective, it brings so much more fulfillment for people working within the health system. So I think, yes, there's a lot of change that needs to happen, but actually it's about our outlook and who we are being when we're sitting with patients, not necessarily what we are doing. And of course, doing is important too, you know. If a patient comes in with rectal bleeding, we need to make sure it's not a colorectal cancer or whatever it is. So doing is really, really important, but it's often who we are being that is more important. And if we're going to be a clear mirror for patients, then we need to look at ourselves.
Yeah, thank you. I'm really pleased in my heart that you brought it back around to providing more space and care for practitioners. Because all this time you're talking, I'm also thinking about how we're living through this post-COVID scenario and all of those experiences now that practitioners are just probably stacked inside of them. I don't know, has there been any sort of care coming in the post-COVID world we live in today to check in more with the experience of these people who survived this experience? As practitioners?
Yeah, thank you. Thank you, Jem, for asking that question, because COVID was huge. And of course, many health workers died as a result of working during COVID. And there was some money around at the time of COVID, which prioritized health worker well-being. And there was increased services such as counselling services and support services. But that was during the COVID period, and that money is no longer there. So it's kind of, we've gone back to almost revert it back to how things were. I think there have been some changes in that there's much more work now is done remotely and done on the phone, which can make the workload a little bit more manageable, although that has its own challenges. But I think this idea of health worker well-being and welfare is hugely important and hugely undervalued. And I think that in the health system, health workers are not looked after. And certainly during my training as a junior doctor, and Gabor will talk about this, I was very disconnected from my body. And that was very helpful, actually, when training to be a junior doctor and doing really long hours, sometimes not getting to eat or even to drink enough fluid, and to do night shift after night shift. It's a really tough environment to work in. And it's often done with very little support. And as long as we have health workers who are under that level of stress and whose nervous systems are so dysregulated as a result of that stress, we're really going to limit the capacity for healing in our patients. In fact, understanding what I do now about nervous system regulation, co-regulation, the sympathetic and parasympathetic nervous systems, how we are in ourselves. Often our nervous systems are so on edge. Healing isn't possible. Like we know this from the science. Healing isn't possible unless we are in a state of relaxation and connection and regulation. So our health system doesn't facilitate healing. And ultimately, my belief is that healing is possible for everyone, and that if we are able to heal our patients, we empower them and we reduce our own workload. But of course, we're so busy in this state of overwhelm and firefighting that it's very difficult to create space for that.
Yeah, I would love it if we could go back to this conversation a little bit about noticing the sympathetic state that you're observing, and just break that term down a little bit more about what that means, what that looks like when you come on. It's like you've taken this 4-year break to study compassionate inquiry and come back with this incredible treasure in your hands, and you're seeing what you're seeing. Share with us what that looks like for you. Maybe tell us a story if you've got one.
It's been so interesting to come back with these new eyes, and a really lovely encounter I had with a patient fairly recently, which really for me illustrated the power of this work, was a woman who came in to where I was working as an out of hours emergency GP. So I do a little bit of emergency GP work as well. And she came in with jaw pain, and she had a diagnosis of TMJ, which is temporal mandibular joint, which is the jaw. So she had a diagnosis of TMJ pain or tension or dysfunction. And she had been backwards and forwards to her GP a number of times to get painkillers for her jaw. And she'd been referred to the maxillofacial surgeons, who are dental surgeons who can insert various mouse guards into the mouth to relieve some of the tension in the jaw. So she was on a waiting list to see these surgeons, and she came in because her jaw was so painful. And I sat back and I was listening to her story, and in compassionate inquiry, we really learn to listen beyond the story to what the patient is telling us with their bodies and with their nervous system. And I really noticed that she was speaking really, really quickly. She was telling me her story really fast, cramming in all of this information that she wanted to impart to me. And I really noticed that her shoulders were right up almost to her ears, and her breathing was really shallow. And she continued with her story for a few minutes. And then I said, could I just interrupt you for a moment? Which is what we do in compassionate inquiry quite a lot if patients or if clients are in their story, So I said, would you mind if I interrupt you? And I said, I'm just noticing how quickly you're speaking. So I just mirrored back what I was seeing. And she said, oh yes, doctor, my mind goes at 1,000,000 miles an hour. And I'm always really, really busy. And I always speak really fast. And I said, okay, thank you. And then I said, and I really noticed that your shoulders are raised up close to your ears. And she said, yes, I can feel all this tension in my body. And often I find it even hard to breathe. And we had a conversation about the tension in her body and about how quickly she moves in her life. And it didn't take very long. It took a couple of minutes. And then she said to me, after me mirroring back what I was hearing, she said to me, "Do you think this is the reason I have jaw tension?" And I said to her, "What do you think? Like, what do you think? I can see all this tension in your upper body. Would it make sense that you would have jaw tension?" And she said, "Yes, absolutely. That makes total sense." And we had another couple of minutes conversation about what she could do in her life to bring a sense of calm and what she enjoyed that gave her space in her life. And then at the end, she said, "What can these surgeons do for me?" And I said, "Well, they may be able to help alleviate symptoms a little bit, but to be honest, I don't think they're going to be able to do much for you." And she said, "I think alleviating this tension is going to be a lot more helpful for my jaw." And I said, "Yeah, I think you're right." And she left my office with a completely different perspective. And what was really interesting, which is what I find over and over, is that patients know, it makes sense to them. It made sense to her that she was moving at 1,000,000 miles an hour and she had this tension in her face. And what was interesting for me is that I wouldn't even have noticed that 4 years ago, 5 years ago, before I did compassionate inquiry, because I would have been in a similar state. It was because I was able to sit back and I was fairly well regulated. And I'd worked on my own anxiety and jaw tension, that it was really clear to me what was happening in her body. So when we're regulated, we're able to notice what's happening in our patients much more. And even though I think probably most doctors and nurses wouldn't describe themselves in those terms of being in sympathetic or being in fight or flight, really what it means to me when I observe what's happening in my colleagues is that they're really, really busy and really stressed, and they don't have a moment to pause or to sit down or to notice what's happening within them. And they're often very stuck in their heads problem solving, which is required. It's required in the job. But when we're able to be regulated, and just something very simple, I mean, this is one of the things that I discuss with other medical doctors who are doing compassionate inquiry, is how do we bring this work into medicine? And we can't do compassionate inquiry sessions with patients because we don't have that kind of time. But we can use some of these very simple practices like mirroring back, which can be so powerful. And for this patient, she's now orientated in a different direction. She understood that maxillofacial were not going to be able to heal her jaw pain, and that there was other things that she could do for herself.
Yeah, that's a really important point you bring up, that while the system doesn't provide space and opportunity for a 40-minute compassionate inquiry session, it doesn't mean that we're not able to glean so many tools and gifts and offer them in the time that you are with a client. And one of the things you said was, one of the options is we could look at the clients as problems, or we could look at the system as problematic. And often clients come under a lot of questions that make them feel like they're doing it all wrong. And it's hard enough for people sometimes to come to the doctor. I have a relative that I can't even talk into going. So I can just imagine that when you get there and you're being made to feel like, well, you're doing this wrong, you're doing that wrong. Given what we know about core beliefs in compassionate inquiry, what would you say about that approach of making the client wrong? Yeah, I'll just leave it. I'll leave it right there.
Yeah, it's one of my core beliefs, like I'm doing it wrong or I'm wrong. So that resonates really strongly, that question. I think what we ask in medicine is, what's wrong with you? And then we attempt to problem solve. And when we can ask, what has happened to you? It brings an enormous sense of compassion to the patient. And it helps them to understand that they are doing their best and that they've always been doing their best. And that some of their behaviors or strategies that they've adopted that may have a negative impact on their health, they've adopted for a very good reason. And when we can have that compassion, it helps us to see patients in a different way, and it helps the patients for themselves to see themselves in a different way. And that brings a softness and an opportunity to move towards healing. And, I have so many examples of this with patients. Can I share a story about a patient? There was a patient that I spoke to who had chronic abdominal pain and constipation, and she was in her mid-50s. And she had had many, many investigations, all of which came back normal. And she had struggled with this chronic abdominal pain, constipation, rectal bleeding from hemorrhoids for about 3 years. And I asked her, what happened 3 years ago when your symptoms first came on? And that can be a useful question. Sometimes it's not, but it can often be quite useful. And she described a number of stressors in her life. And I was able to share with her about the gut-brain axis. And I talk about this with patients a lot, is that the gut is a very important part of the nervous system and it's very sensitive to stress. And the gut will respond to stressful situations in our lives. And that really made sense to her. Well, as I was speaking to her, I was flicking through her notes. I was talking to her on the phone and I could see that she had a number of significant adverse childhood experiences. And she actually asked me, do you think this is anything to do with my childhood? Which is really interesting. So she also had a kind of an idea of this. And I said, well, we know that childhood adversity has a huge impact on our physical health. It would make sense that your gut would be sensitive to stress. And we know that toxic stress in childhood impacts the gut and the nervous system. And we had a short conversation about that. And she said, that's what I thought. That makes real sense to me. And she said, I asked my GP recently if he thought that my gut issues were to do with my childhood. And he said, no, don't be silly. And it was very validating for her to have this new understanding. And she said to me at the end of the conversation, I don't think I need any more investigations, do I? And I said, no, I don't think you do. She'd had all sorts of scans and scopes and all kinds of investigations on her gut. And she said, thank you very much. And she went away with the books that I recommended. So I recommended When the Body Keeps the Score by Bessel van der Kolk, and I recommended Nadine Burke-Harris's book, The Deepest Well on Childhood Adversity, which I think are two wonderful books that are very accessible and explain some of this work really well. And what was interesting is that she didn't ask me, what do we do now? And this is something that is really interesting because I teach some of this work to doctors and to medical students. And the question that I get asked the most is, if we open up this conversation, what do we then do about it? And I think there's a fear of having these conversations because doctors don't perceive themselves as having the training to then follow up and know what to do. And my response to that is that often we don't need to do anything. This patient left knowing that she didn't need any more investigations and that she could read these books and begin to empower herself to bring practices into her life. That because When the Body Keeps the Score and Nadine Burke-Harris's work are full of evidence on practices that we can use to bring regulation to our nervous systems. And it's usually doesn't involve pharmaceuticals. And there are very many practices. And they're different for each different person. So everybody has to find their own way with this. But she now had the knowledge that this was about how her body was responding to stress in her life. So we avoided any further unnecessary investigations. And she wasn't asking me to do anything. And I think we underestimate, because we're sort of locked into this doing, that we always have to be doing something, investigating something, doing something to the patient or for the patient. We underestimate the power of our voice as doctors to make that link for patients with what has happened in their childhood, what are the current stresses that are happening in their life, and how that's showing up in their bodies now. And often that's all that patients want. Sometimes they'll ask, okay, where do we go next? And that's a valid question. But often just having that understanding is really validating and really helpful for them, so that we're not saying there's something wrong with you. What I find myself saying really often to patients is, you're having a really normal response to what's happened in your life. And, you're a human being. And when you are put in this situation that's beyond your control in childhood, your body adapts in a certain way for your survival. And I've had patients cry when I say that, with relief, that they are seen. They're seen as not as defective, but as somebody who's doing their best with what they had. And that's really powerful for people. And we often don't need to do anything else. People want to be seen. And if we can give them,
be seen.
Yeah. If we can give them that gift. Yeah, it's a positive shift. Yeah, please do. Yeah.
For just a second, because you've said so many things that I want to touch back on. And well, first of all, I'm giggling a little bit over here to myself as we're talking about this potential that exists for doctors and the relationship they have with their clients. And I'm thinking about the thing we always hear when it's our turn. What do they say? The doctor will see you now.
Yes. Yes, nice. Yeah.
You're actually talking about a situation where the doctor actually sees the patient and doesn't just bark questions and protocols and prescriptions at them. That's often not what they're looking for. I feel the relief in my body as you describe the relief that your patients feel when you ask a couple questions. It's just really interesting to me to hear you reflecting the ways that incorporating something like the compassionate inquiry approach into the way that clients are assessed seems like it would create a whole lot of work. But what you're offering in your experience is that it's actually put the power back into the knowing and the experience of the patient, and that you don't really have to do that much.
Yes, exactly.
And there's one question I wanted to ask as you were talking about this client and they had the adverse childhood experiences.
Right.
That's the ACE study, just for people who aren't aware. It's a study called the ACE study. Do you want to talk a little bit about what that is? And then a follow-up question to that is, do you have that on your intake form? How did that come about?
Yeah, great. That's a lovely question. So the Adverse Childhood Experiences study was a very large study done in the 90s in San Diego by Center for Disease Control and Kaiser Permanente, who were a large healthcare provider in the States. And they asked 17 or 18,000 patients, so it's a very big number, about their current health conditions. And then they asked them about 10 adverse childhood experiences, such as abuse, neglect, parental divorce, parental incarceration, addiction in the household. And they showed a lot of different really interesting findings came out of that study, but they found that ACEs are very common. Adverse childhood experiences are experienced by 2/3 of the population. That I think it's 15% of people have experienced 4 or more ACEs.
In 2018, the largest study to date measuring ACE scores was conducted. It assessed nearly 250,000 people, and it was conducted in the United States. Among the results, indeed, it found that 15.8% of the population studied reported having 4 or more adverse childhood experiences, or ACEs. That number is pretty significant considering those who reported having 3 ACEs landed at 8.8%, and those respondents reporting 2 ACEs was at 13%. So that leaves us with 23.5% of the population studied reporting a score of 1 adverse childhood experience. So now we arrive back to that number that you might have caught. 2/3 of the population studied had reported having at least 1 adverse childhood experience. You can find a link to the ACE questionnaire in the show notes. Additionally, we'll provide a link to that study that's cited in this episode.
And what they found was there was a huge, very strong correlation, stronger than the correlation between smoking and lung cancer. So this is very significant, between levels of childhood adversity and ill health in later life. And this wasn't just mental ill health or physical ill health secondary to health harming behaviors. This was independent of what we might call like smoking or addictions or anything like that. And it was an significant increase of ill health across really all the chronic disease systems. So increased rates of diabetes, stroke, heart attacks, autoimmune conditions, cancer. And at the time, they were really excited and thought this would really be a game changer in medicine. And it really fell a bit flat. And it's only now, kind of 25, 30 years later, slowly penetrating into the medical system. But still, when I do ACEs talks to doctors, there's still the minority have even heard of the ACEs study. And there is a move towards routine screening of ACEs, where when you sign up to a medical practice, for example, you're asked about your ACE score. And what has been found in preliminary studies in the UK is that just by asking that question and doing the ACEs screening has a positive impact on patients. And I think the reason for that is that they perceive themselves as being seen. And they also start to make the link between what's happened to their childhood and their health in later life, which helps them understand themselves better. And one of the barriers to us discussing this as healthcare providers is what we've been talking about, which is that there's a perception that we're going to have to do more, or that we don't have the skills to have these follow-up conversations. And actually, what I have found, I mean, I can't tell you how many times over and over again patients have been coming with a particular condition, with normal investigations, and they keep coming back. And the reason that they're coming back is because they have persistent symptoms and they don't understand what's happening inside of them. And they're often quite scared because we haven't been able to give them an answer. And people very understandably can catastrophize and start to believe, oh my goodness, maybe there's something really wrong with me and I've got cancer or I'm going to die or something. And I've had this conversation and made the link between childhood adversity and stress and what's currently happening in their life. And almost always I can see the penny kind of dropping and the patient going, oh my goodness, okay, I get it. And they stop pursuing investigations. And that is huge, for the patient and for the healthcare provider. It's very impactful for people.
Right. Just opening up that inquiry and providing that potential path for, I had a feeling this was connected.
Yes.
That validation right there. Are the ACE questions on your actual intake form when you see clients?
When I see clients, so not in my GP work, because that's, not part of what we do in the health system, but when I see clients privately, I will often go through, what is their ACE score? Yeah, absolutely. And I think, doctors are reluctant to talk about this stuff. And actually, I find it to be much more straightforward than people think. And again, having learned from compassionate inquiry that when we ask consent, really it's patient-led and we're only going where the patient wants to go. So I'll just say to people, would it be okay if I ask you a few questions about their childhood? And most people say yes, and some people say no. So if we ask consent, then, and we have and the patient agrees, then it's really okay to have these conversations. And we have difficult conversations as doctors all the time. We break bad news. We discuss difficult diagnoses. So I don't really see this kind of conversation as any different. And the other thing that I've really learned is that we actually don't even really necessarily need to talk about anything to do with the childhood trauma, because as we learn in compassionate inquiry, what is significant is what shows up for us in the present moment. Gabor says, tell me about the last time you were triggered and I'll tell you about your childhood. So it's actually what shows up in the present moment that's important. For example, there was another patient that I saw who also had gut issues, and he was he was a patient where I was working in a practice for people experiencing homelessness, where I worked for about a year. And all of my patients in that practice had ACE scores. So the ACE score is out of 10, childhood adversity score. And all of them had 8, 9, 10, and probably actually 15, of other things that weren't measured in the study. So they had very, very high levels of childhood adversity. And again, he actually had vomiting and weight loss and was really struggling to keep weight on. And we were actually prescribing build-up drinks to him. He was a young man. He was only in his 20s. We were prescribing build-up drinks to him, which are only usually prescribed for patients with cancer who need to put on weight when they're going through chemotherapy. So this was quite extreme case. He was many times come backwards and forwards to the GP trying to get answers. And he had a long, long, long list of investigations, all of which were normal. And I did create a little bit of extra time. Sometimes we do need extra time for these conversations. And I was able to sit with him at the end of a clinic for 20 to 30 minutes. And I actually talked about the ACEs study. And I said, we know from studies now and from the data that high levels of adversity in childhood have a really significant impact on your health in later life. And I'll never forget it, because he looked at me and he started to cry. And he cried for about 5 minutes, and I sat with him. And at the end of that conversation, he said, I don't need any more tests, do I? And I said, no, I don't think you do. And we didn't discuss any of the details about what happened to him in his childhood, because we didn't need to. We both knew that he had high levels of childhood adversity. And we both recognized that that was showing up in his body in the present moment. So we don't need to kind of go there and talk about these painful experiences. And sometimes, yeah, of course, that's more appropriate in the container of a relationship with the therapist. But just acknowledging that connection and acknowledging that that's showing up right now in the present moment is enough, is more than enough.
It's so powerful. Thank you for that story.
Mm.
I really appreciate all the stories you've shared. And I don't mean to be excessive by bringing in yet another client experience, but I feel like this is really important because I have some questions about autoimmune disease in particular that I'm very curious about. We haven't had really an opportunity on the show yet to underscore the connection there. So I'm going to read this quote. This client says, "It's so hard to put into words how much the work I did with Aisling has changed my life. I've lived in my head and on high alert mode most of my life, increasingly overwhelmed and exhausted, unable to even see how to take care of myself on top of my children and parents. I'm now noticing, paying attention, feeling, and even enjoying more. I feel more whole, more grounded, more genuinely grown up, more together, and more hopeful about the future. I have an autoimmune condition, and I don't think it's a coincidence that my most recent blood tests revealed the lowest ESR and CRP inflammation markers in 3 years. I could not have figured out all of this on my own, and I am so happy and honored to have met Aisling, to have had her to listen to, understand, support, and guide me through the compassionate inquiry process." So that's just a bucket of what we've been talking about already. What really pops out to me is this last sentence, that this person is so happy and honored to have met you and had you listen to, understand, support, and guide them. They just wanted to be heard, is what I'm hearing right there. So before we move on, and I ask you specifically to define autoimmune disease, can you also, for the listeners, what are ESR and CRP levels? What do those mean, and how do they relate to autoimmunity?
Yeah, thank you, Jen. So these are inflammatory markers that are measured on a blood test, and they are a marker of inflammation in the body. And I felt emotional listening to you reflect that testimonial back, because I haven't read that for ages. It's on my website, but I haven't heard it read back to me. And this was a wonderful patient who I worked with for a year. And this is the power of compassionate inquiry when I can do it outside of my GP work, and really start to go deeper with patients. So this patient had an autoimmune condition. She was on very strong medication for this. And these patients are followed up usually 6 monthly or annually by usually, secondary care. So these are hospital doctors, and they get blood tests regularly to monitor the strong medication that they're on, and also to look for levels of inflammation in the body. And her inflammation levels were always fairly high. And we were able to work with compassionate inquiry. And as so often is the case with people with autoimmune conditions, she from childhood had learned to put her own needs last. And she was working very hard to care for everyone around her, which meant that she was very stressed herself. And she found it really hard to say no. And this is where the book, The Body Says No, comes in, And she'd read Gabor's work and she understood it. And I was able to support her to begin to say no in her life, and to create space to take care of herself and to do the things that she loved, such as going to the sauna and gardening and, asking for help and saying no to others. And when she was able to do that, her inflammatory markers came down to normal and stayed down from then on, which was really powerful for me and for her, because that was something that I could never do as a GP. And she actually, at the end of our work together, began to come off her very strong medication that she was on for her autoimmune condition. And
Aisling, just one thing I'm wondering. Are you able to share what that condition was and what the medication was, just for anybody listening on who might be piqued in their curiosity?
Yeah, sure. So so the condition was rheumatoid arthritis, and she had quite significant rheumatoid arthritis, which gave her a lot of pain in her body, and she had deviation of the fingers and the joints in her fingers. and deformities in the joints in her fingers. And she was on methotrexate, which is a pretty strong medication that has various side effects and requires monitoring. So she was able to start to wean off her methotrexate. And her rheumatologist, so she was under rheumatology, who, would monitor her medication, her bloods. And the rheumatologists were very hesitant about her coming off her methotrexate. And, some people need medication, and that's absolutely fine. I'm not against medication at all. And, it's really necessary and helpful for some people, and that's okay. But she wanted to come off her methotrexate, and she'd made really, really significant changes in her life, which I was very confident meant that the stress levels in her body were much reduced, and her bloods were reflecting that. So I was very supportive of her coming off the methotrexate. I think the rheumatologists were a lot more nervous about that, but they didn't, in my view, they didn't have this perspective of how many life changes that she had made and how she had brought down the stress levels in her life. And she was able to successfully reduce the dose of her methotrexate, and therefore reduce some of the side effects and some of the risks. And she's still on a low dose, and she's okay with that, So it's not always, for me, it's not about coming off medication, and it's not about normalizing inflammatory markers. It's about coming closer to our authenticity and to who we really are. And as a side effect of that, it often means that symptoms resolve and patients may come off medication, but that's not the goal. The goal for her was to be able to say no and create more space for herself. And when she did that, the sort of the blood tests followed. And I've had a number of patients who have come completely off medication, particularly psychiatric medication, such as, anti-anxiety tablets, or what we call SSRIs, antidepressants, or diazepam, which is often prescribed for anxiety. And when we're able to create space in the body to be with sensations of anxiety and emotions of fear, and we're able to understand and bring compassion to why we're experiencing those sensations in the first place, then we are able to move towards healing. And then often the medication isn't necessary. And again, some patients need medication. There's nothing wrong with that. It's very helpful. I prescribe these medications still quite a lot, but when we do this deeper work, often we are able to heal and come off these medications, which as a doctor it's hugely rewarding. And it's wonderful for the patients. They don't want to be on medication for the rest of their lives. And what's really beautiful is that I've had this reflected back to me from this particular patient we've been talking about. She said, when my joints flare up and when I get pain in my hands, I take a pause, and it's an invitation to look at my life. And there's usually something that I'm doing that I need to not do. There's usually something I've taken on, or somewhere where I'm pushing myself. And it's the same with some other clients that I've worked with. One I'm thinking of who had very strong anxiety and was on quite high levels of psychiatric medication. And he was able to come off those over the year that we worked together. And he said, at the end, when I get this churning feeling in my chest, it's a signal to me. And it helps me, because I realize that there's something that I'm doing in my life that's causing to increase anxiety levels in my body. So I'll say no to a project in work, or I will cut back on this, or I will, make sure that I'm doing my yoga, or like whatever it is. So it becomes an ally. These symptoms become an ally that are telling us about something, reflecting something that is going on in our lives, and they can be our friends. And when we battle against symptoms, it creates so much stress and tension in the body itself. Just by that battle, we're trying to push the symptom away. We're making ourselves wrong for it. We're creating a story about something wrong with me. And all of that creates tension in the body, which adds to the stress that we experience. So by bringing compassion, it opens up space, and it brings a softening, and it allows these symptoms to be there. And when we stop fighting them, it's like what you learn in compassionate inquiry about will and counter will. And I often think of that with symptoms. The symptoms are telling us something, and we're trying to push them away with medication, and the symptom starts to push back. So when we create space where we're not imposing that counter will on the symptoms, and we're approaching the symptoms with curiosity. And often just doing that can help the symptoms to settle.
Wow. These are really incredible connections you're making with the terminology from compassionate inquiry and the things that we learn. It's really fun for me to hear you bringing these medical examples out. And, you talked about how your goal is not the lowered inflammation markers. It's not, your goal is authenticity.
Mm.
And what I also hear in that is your goal is to bring that connection back to themselves, for them to feel more connected to themselves. And by the way, as you were describing that patient who was running around, taking care of everybody else's needs, their needs came last, unable to say no, overworked, I'm thinking a lot about your colleagues again.
Yes.
I'm thinking about how Gabor said in one talk that the things that we're appreciated for are the things that kill us.
Yeah.
And bringing that conversation in and really bringing more compassion and space for practitioners feels like something that it's a reciprocal relationship that you're describing, that we as patients could see more potential in our care providers and medical providers and have more compassion for how overworked they are, just as well as being seen, this request to truly be seen. When you're at work, you're referred to as Dr. Quiery.
Yes, or Aisling. Yeah, I prefer Aisling.
Aisling. I think that's really fun, though, that your name is Dr. Aisling Quiery, because you ask questions. There's so much, I think, that your experience is showing that can teach the way forward for the medical model. And so in closing, because this podcast is so invested in creating a platform for teaching and showing the world what compassionate inquiry looks like as it starts to find its way into different modalities and services and institutions, what's one thing compassionate inquiry has to teach medicine that could really transform it?
Yeah, great. That's a lovely question. So when Gabor was on the podcast, he talked about curiosity. And of course, compassionate inquiry is about curiosity and asking questions. And I think what I would love most for the medical model is that we become really curious, that when patients come to us and we don't seem to be able to understand what's happening from a medical point of view, that we become really curious and look a little bit more widely as to why that might be, and to ask questions about what's happened to them. And I think if we can come back to a place of curiosity, we can really shift how we practice medicine. And I think curiosity is also really difficult when we're in overwhelm and when we've got too much to do and when we just want to, get on with it and problem solve and get the patient out of the room so we can see the next patient. And I totally get all of that. But I would love it if the medical model could be curious about why is it that we don't seem to be able to figure out what's wrong with many of our patients. I wonder what is missing. If we could ask that question, I think that would be really transformative.
Absolutely. I feel such a opening in my heart and relief in my bones to just ponder the notion of a more inquisitive and curious model for medicine, not just for patients, but for those on the other side providing the services. This has been a wonderful exploration about possibility and reimagining the medical model. So Aisling, thank you so much. It's been such a pleasure to talk to you, and I really admire and appreciate you.
Thank you, Jen. It was really lovely. Yeah, thank you.
The Gifts of Trauma is a weekly podcast that features personal stories of trauma healing, transformation, and the gifts revealed on the path to authenticity. Please note, this podcast is for informational purposes only. It is not a substitute for personal therapy or a DIY formula for self-therapy. We'd like to thank you for being here today, and we'd also like to thank our guests, as well as Gabor Mate, Sataram Kaur, and the Compassionate Inquiry admin team, marketing team, and podcast team. Please join us again next week to hear more stories of transformation and healing through Compassionate Inquiry.